Thank you for the opportunity. I would like to present you my PhD topic, which is the application of artificial intelligence in COVID-19 severity prediction. I'm Márton Rakovics, and besides being a PhD student here, I'm also an assistant lecturer of statistics at Translational University. I have two projects ongoing. The first one is a meta-analysis. It's the investigation the efficacy of the early severity prediction models in COVID-19, and the second one builds on the meta-analysis, and it's a development of a novel prediction model for COVID-19 as well. So regarding the first topic, we pretty much well know COVID-19 by now. We've seen around 700 million cases so far around the world, with about 6.8 million mortalities and about a 15% ICU rate. And the characteristic of this disease is a sudden regression of patient condition. And we see that even in very well-developed countries such as Switzerland, above 70% ICU occupancy, patient outcomes get much worse. So we think that it's really important to be able to choose the right tool for early severity prediction because it helps us to manage our limited resources. And there have been numerous such tools developed so far, and our aim was to quantify the performance differences between these different tools. Regarding our population, we've looked at hospitalized COVID-19 positive patients, and we are comparing the different prediction models, prediction tools, and the outcome we're looking at is severity, basically a binary outcome, severe or non-severe, and severe can be mortality or ICU or mechanical ventilation. We saw that these do not really, that doesn't really make a difference in terms of prediction probability. Our hypothesis was that AI tools, so deep learning technically models, are superior to simpler ones. The systematic search was done in these databases, and we identified 27,000 articles, and after a selection process, we ended up with 430 articles from which we could extract data from. And it's really important to stress that there was a high heterogeneity in these studies because, of course, these were very different patient populations from around the world in very different environments. So we really put an emphasis on identifying the possible confounders, and we used the metaforest algorithm that was specifically designed to tackle such a task. Because we were interested in basically differentiating the performance of three tool types, the sort of most simpler ones, the linear classifiers. You think of the simple nomogram style tools, the machine learning models, and we did a sort of subgroup of machine learning models, what we would call AI models, the neural network models. We found that in terms of confounders, region was very important, the rate of severe cases in that subpopulation, and of course sample size was important as well, besides the use of C-reactive protein as input to the prediction model. One of the primary findings was that area under the receiver operating curve, so AUC, was better in neural networks and machine learning tools than in the simpler linear classifier models. This is already an adjusted result, so it's not just some raw differences. By looking at this, we might not find this a very convincing difference in terms of clinical relevance, but if we look at the sensitivity and specificity of the models, we see that there are actually very important differences between these tool types. So if we look at this graph, the dots represent the adjusted pooled sensitivity and specificity values, but we could tune these models differently. So if we compare the sensitivity is at the set 20% false positive rate. So if we draw a vertical line at 0.2, then we see that linear classifiers only have an 80% sensitivity, while neural networks have a 98%. So there's a huge difference there. It's even more striking if we consider the actual application. If we look at a sort of a hypothetical comparison where we have 100 patients with 10 severe patients among them, you would see that linear classifiers identify 6 patients correctly, while the neural network 7. So they are pretty comparable. But the huge difference is for the false positive cases. So the false positive number is reduced by 56%. And that, of course, leads to a much lower ICU burden. So we don't miss the critical, actual severe patients, or we miss a similar amount of them, but we lower the ICU burden by a lot. In general, we could say that all machine learning models perform really well, and it's worth replacing the simpler clinical scores and transition to these stronger models, specifically neural networks, as soon as we can. I think that one of the strengths of our study was the unique breadth and depth, and I think we can actually help clinicians in choosing the right prediction tool. And some of our findings, I think, can be generalized, so they are not only applicable to COVID-19. And among the limitations, I would say that there are some possible confounders we could not control for example, the differences in hospitalization policies that may affect the results to some degree. So right now we are at the end of the internal review of the manuscript, and we'd like to submit it to Science Advances. And my second topic is about the development of a novel prediction tool, and that we found that it was we could really build on the previous meta-analysis in doing this. It's a registry analysis based on primarily the Corona app and the COVID-19 registry and biobank, and it's important. I would like to thank all those working in these registries, because without them we could not do this data analysis. But we are using additional data which was openly available for this study as well. I talked about the background of COVID-19, so I would like to highlight some of the methodological related important things here. That primarily that a recent Nature Medicine review found that there are there's an untapped potential in AI models, deep learning models, most notably the use of transfer learning. So we can aim to incorporate knowledge into the analysis, which we've gathered previously, and the use of unstructured data, so text information from medical notes and similar things. Our patient population is the same, hospitalized COVID patients, and we are testing different models, but we would like to develop a sort of a GPT type of prediction model, specifically a graph attention transformer. We are, of course, assessing the performance of this model using the similar AUC, sensitivity and specificity, as before. We are in the data analysis phase right now, and things are very promising. We were able to incorporate external knowledge using clinical concept embeddings. Those were constructed from a huge database of medical scientific texts and from health insurance data. And based on these embeddings, we could construct a medical knowledge graph, and we can infuse this medical knowledge graph with our actual data values and use this graph attention network to arrive at predictions. And hopefully we'll finish with this project as well. Thank you for your attention.
Thank you for this wonderful talk, and I think that this presentation showed us that the power of AI is very, very important, and I'm pretty sure that in the forthcoming years, not just at the CTM, but also in CTM, we will see many more presentations about AI and how to use it in the field of medicine. Any questions from the audience?
Thank you for your presentation, Márton. It was really great. I have a question not regarding the statistical background, but you mentioned that regarding the second project that you use data of local institutes or hospitals, but also from other databases openly available. What are these sources of data? The other.
Yes, thank you for the question. So these are very similar to our own databases collected at different hospitals from around the world. So if these are available, so we thought, why not choose it?
It's easy to.
Sorry. Well, fortunately it's fairly easy to come across these data sets. COVID-19 was such a case where scientific publications were made openly available, and the sharing of data was very much encouraged.
In your first project, you mentioned that location was one of the things that was an important factor. So when in your second project, when you select these different kind of data pools, do you use that knowledge that you gained from the first study, which locations not to choose or which locations to choose?
We don't need to exclude any locations. We just now know that it's important to incorporate that specific information into the prediction, so we won't miss that.
So you haven't identified any sort of cohorts that you think were, statistically speaking, less accurate than other ones?
Maybe not that, but we found that Chinese studies reported higher accuracies. So we were really active in trying to figure why that is the case, and probably their sort of patient population was simply more homogeneous. On the one hand, on the other hand, they were actually the ones using the most sophisticated prediction models, and they just built better models.
I would like to ask one more question. Do you have any specific system that can be advised to the Semmelweis ER department? Maybe what to use right now at the moment to predict which COVID-19 patients should be sent to the ICU?
If there aren't that many patients hospitalized, I think we can err on the side of caution. So it doesn't really matter right now. It was more important when there were many incoming patients. So in the future, whenever there's some kind of new disease where again the burden on the ICU would be potentially very high, then again it would be more important. But it seems that we don't really need a lot of patients, especially when we're incorporating external knowledge to build, for example, neural network models. So I would say that next time, do that as fast as possible or as early as possible, and don't be afraid to sort of switch to that instead of using the usual severity scores.
Thank you.
Hi, congrats. I'm always amazed about your data and passion. My question here is that if you can use, or is it possible to use any automated data gathering for those different locations, different systems, or in your second study, for example, are you having someone who is extracting the input data which is needed for the big data set on which the AI can learn?
I don't have to do it, fortunately. It's been done for me. I mean, clinical, the medical knowledge graph is built on a data set that was compiled by researchers at Stanford, and I think I wouldn't probably wouldn't be able to do a better job than them.
But if you are building a new prediction model based on a neural network, or I don't know the data set, how you should make it learn, can you make it automated, how it's gathering data from Metzol, Emma, and all those different systems? Is it easily possible in Hungary, for example?
In Hungary, I'm not so sure, but I don't think you actually need to do that sort of each and every time, because that data set is completely general. So it contains, for example, almost all of PubMed, and all of the abstracts on PubMed, and a lot of the papers as well. So it's not specific to COVID-19 at all. It's like ChatGPT is built on a very general data set, and you can fine-tune that on some specific problem. This is sort of a similar case.
Then I don't really get the difference between these models and logistic regression. I mean, the bigger input data there you have, the better it aligns with reality. And
well, okay. We don't have time to, but that's
Actually,
not
I was going to interrupt and suggest that you continue this at the coffee table. Thank you for the question, but we have to move on, unfortunately.